Okay, great. Well, let's go ahead and get started today, guys. So hello and good afternoon. For those of you who were able to join us yesterday, welcome back to Spring Break 2020. And for those of you who are joining for the first time, welcome. I want to start off today with some thank yous, though. First, a big thank you to our administrative staff, and in particular, Katie Costin for all her behind-the-scenes hard work, which is what made this meeting go from an idea on a text chain between a bunch of friends to actually happening. So thank you very much. And also thank you to our team from AnyScreen for their technical support. Also, thanks to our moderators and speakers for presenting at this meeting. These are people who have volunteered their time and their expertise. Some of them were doing so from the epicenter of the COVID pandemic in New York and New Jersey, here in the US, and we really appreciate your involvement with this. And also thank you to our attendees who are filtering in this morning. So thanks for taking the time to educate yourself and for participating in the discussions by asking great questions. And we've been having a lot of great questions, a lot of good back and forth. And it's a very chaotic time, so thank you for taking your time to be here. And we've really been overwhelmed by the reception we've had for this meeting with over 700 people, which is amazing. I also want to add that if you've been enjoying this content and you want to see more of it in the future, please take a minute to join the SVIN as a member. Joining as a member goes a very long way for us in helping bring content like this, and also supporting the many other things that we do as a society, which includes advocacy for our specialty, hands-on training for fellows, and funding to support research, particularly for fellows and for early career faculty. I personally have benefited a lot from career development awards from the SVIN, and that's what actually led me to become more involved in the society. So if you can take a minute to join as a member, it really helps. And Trish and Katie, maybe we can send a link to membership in the chat. And finally, one last plug, which is for our annual meeting. It takes place in November every year. This year it's going to be in sunny Los Angeles. It's a great opportunity to meet people in person, if you can remember what that's like to meet people in person. But nearly all the speakers on this conference will be there, plus many others. And this is particularly helpful for trainees who are thinking about fellowship, applying for fellowship, or finishing fellowship and looking for a job. It's a great venue to meet program directors and fellow trainees to help you along that process. Okay, but without any further ado, let me introduce our first speaker for today. Dr. Wandwasan Tekle is a vascular neurologist, a neurocritical care specialist, and interventional neurologist. He's an assistant professor of neurology and radiology at University of Texas, San Antonio and Rio Grande Valley. He serves as the director of the stroke and neurocritical care at Valley Baptist Brain and Spine Network in Harlingen, Texas. Dr. Tekle received his medical degree from Addis Ababa University in Ethiopia, and then completed neurology residency at George Washington University, followed by fellowships in stroke, neuro-ICU, and interventional neurology at the University of Minnesota. Today, he's going to be talking to us about ICH, Clot evacuation, and NOAC reversal. We'll have time at the end for questions, so please do enter those as he's speaking. Dr. Tekle?
Okay, here we go. So now I click for the connection. Okay, perfect. Still slow, but oh, it's advancing. Okay, good. Okay, guys, I'm so sorry. We had to change a new network connection, and then hopefully this will help us to go through this thing. And thank you for your patience. I apologize for that. Okay, so we were here. So then conventional craniotomy and evacuation of hematomas failed. So then the focus has been for the last several years really MIS, minimally invasive surgery. There's two types of MIS. One is pharmacologic based and the other one is direct mechanical. Pharmacologic based technique, it really is, I'll show you in the next slide. And like in this slide from NIST-2, you notice that there is a right basal ganglia clot, and through the right frontal approach, there is a catheter placed in the depth of the hematoma, and then PPA is infused out of place 1 milligram every 8 hours, and there's a 3 cc of saline flushed behind it, and the EVD or the drainage system is closed for an hour, and after an hour, it's opened for gravitational drainage. This was done up to 3 times a day for 3 to 4 days, and then that would be it. And as you can see here, as an example, progressive reduction of hematoma over a span of 3 to 4 days. Now that is the catheter-based primary pharmacological catheter-based mechanism. The second one is primary evacuation of the hematoma. Just before I go there, there is somehow one in between. This is a hand drill held, a drill held on a hand, basically, and the person has a craniopuncture at the specific site, and they will pull using a 20 cc syringe to try to pull as much clot as they can, and then they leave one of the sheath that you see here, and then they leave it for a few days. Also, this is kind of in between. It has both mechanical component of the initial pull followed by drainage through the catheter. And the last one is endoscopic approach, some form of endoscopic approach or through a sheath. You basically advance the endoscope, or as you can see, there's a peel-away sheath into the distal third of the hematoma, and then through which goes an endoscope, through which goes a suction system, which I will show you an example later on. And then basically you make your way back from distal to proximal, or from deep to superficial, as you can see here, and then you want to see a result, something like that to the right. So Dr. Kellner and his group from Mount Sinai recently published a paper showing the different techniques used all across the world. The idea is to use all these techniques together and then to do some form of comparative analysis in the future and to see which one has an advantage over the other. The first two on the left side is a craniopuncture technique on the left side, and then the one in the middle is a MISTI technique where you have a drainage catheter in place. And then, of course, these last three are somehow direct endoport technique, through the endoscope technique. This one is through the endoscope. I'll show you an example of these two at the bottom as well. Now, just to go over some of the evidence on this, on minimally invasive studies, we'll start with the ones that are done in the West, and then we'll kind of move to Asia. So MISTI-2, as most of you know, was a phase 2 safety, basically clinical trial that enrolled 123 patients, randomized 2-to-1 to pharmacologic-based MIS, which is what I showed you earlier, versus standard medical management. So long story short, MIS led to a significant reduction in hematoma size and perihematoma edema. However, there was no difference in the primary safety outcomes, which mainly included 72 hours expansion of hematoma. Now you have used TPA, 7 days death at 30 days, and so on and so forth. There was no difference in outcome between the two groups. However, there was slightly increased asymptomatic hemorrhage in the MIS group. In fact, if you put asymptomatic and symptomatic hemorrhages together, there is a statistically significant increase in the MIS group. Now, although this was not designed to be an outcome study, as it's a safety clinical trial, over a year out, it did actually show that there is some benefit in terms of mobility and ADLs, and for those patients who had MIS, as you can see on right here. And this was a good indication to design a phase 3 trial, clinical randomized trial, which I will talk about in just a second. One other point on MISTI-2, as you can see, is that the mean hematoma reduction was 57% only. And also to the right side of this curve, you see the percentile of patients. And if you look at the 50th percentile, that average sort of was 20 cc. This was good, much better than the comparison medical management group. However, the pre-specified percentages were 80%. They did not achieve those pre-specified surgical quality metrics. However, as you see here, the less residual left in the, let me go back here. The less residual left behind their outcomes. As you see more and more residual left behind, the good outcome rates, MRS 1, 2, 3, or 0, are going to be less and less. So MISTI-2 also showed and gave us this indication when it got published. So MISTI-3, the phase 3 trial, was of course due, and then it enrolled 500 patients, more than 30 cc of hematoma, and then it was a dichotomous outcome of good outcome, which is 0 to 3 MRS, and poor outcome 4 to 6, over 78 centers across the United States participated in this trial. And as most of you know, to not go over into too much detail, there was no difference in functional outcome in patients who did receive pharmacologic-based MIS versus medical management. Again, similar to MISTI-1, MISTI-2, MISTI-3 also showed only 59% of patients achieved the target hematoma reduction to less than 15 cc. And they noted that significant benefit of MIS was noted in those patients who actually achieved less than 50 cc of residual hematoma. So you notice, based on MISTI-2 as well as MISTI-3, it was actually not easy to achieve very small residual as prescribed here, less than 15 cc, or more than 80% of the hematoma evacuation was not possible. But it was possible, but it is possible, and this has been shown, through a direct aspiration technique without having to use a pharmacologic technique. Dr. Kellner from Mount Sinai just recently wrote this letter to Lancet, basically showing their technique. And on this gentleman, as an example, someone who had a left beta ganglion intracerebral hemorrhage, and post-procedure, this actually case was done in the cath lab. Only a 1 cc hematoma, or less than 1 cc hematoma, was left behind. So they're basically saying, yes, MIST-3 told us that patients' outcomes can improve if we actually achieve a significant reduction in hematoma volume, and we can do that. This was a case done in the cath lab, by the way. So, so basically, that's kind of where we are with sort of the trials, the most important trials in the West. And as you know, 40% of the patients or more can have a hemorrhagic stroke in the, in Asia, especially in China, Korea, and so on. So a lot of data comes from Asia, really. There's so much literature out there. For example, like this study using that craniopuncture handheld drill device that I showed you earlier, randomized about almost 400 patients, 195, 182 between craniopuncture and conservative management group. And they showed that dependency rate at 3 months was much lower in the craniopuncture group. And so, like I said, if you just go into literature and look into MIS, there is just tons and tons of data, and difficult to see which one is good, which one is not. And again, thanks to the group at Mount Sinai, they were able to do a nice meta-analysis, which basically looked at over 1,000 studies over the last several years and selected only 12 high-quality randomized clinical trials. And specifically, the strengths of their data was about looking at the subsets of MIS, specifically looking which group of MIS or which type of MIS was better than the other, and so on and so forth. So if you look here, really, sorry for busy slides, but if you look here on top, MIS compared to other treatment, which basically includes medical management, watchful treatment, or conventional craniotomy, you notice that the odds ratios are favoring MIS by far in almost all studies. If you look at MIS compared to conventional craniotomy, again, almost all trials showed that MIS was favored. And more on endoscopic surgery or hidden panel D, stereotactic surgery, all of them are compared with other treatment. And again, odds ratio is favoring MIS in all the studies. And another important thing that they looked into is how about the comparison between those patients who got treated within 24 hours and those patients who got treated within 72 hours. And the majority, and almost all patients treated within either time window benefited from MIS. So there's really a significant indication that MIS could work. But again, looking at the data from the West, from the East, and all this meta-analysis done in 2012 and 2018, the last one I showed you, we don't have a randomized clinical evidence, high quality data, so evidence still stays at class 2B and level of evidence B. Now, there are new trials, well, not new anymore, but there are trials, randomized clinical trials using the new generation devices. These are the most common neuroevacuation devices, the Artemis neuroevacuation system from Penumbra and the NICO BrainPath system from NICO corporations. So there are clinical trials actually ongoing right now using either of these two devices, and I'll talk about it a little bit. Just to introduce you to these two devices very briefly, for some of you who may not know them, this is the Artemis neuroevacuation system. It has a wand. This is the evacuation wand, inside of which is a little tube that is a rotating tube. It has a cutting edge at the end. It basically cuts into the clot. Some of these tenacious clots would be hard to suck. So this little tip. So this basically, this cutting edge will cut into that and make it smaller pieces, so it can be suctioned back easily into this tube. This is a similar suction system that we use for LVO thrombectomy. So a clinical trial that is currently running using this device, Artemis device, is called MIND. It is enrolling patients within 72 hours of symptom onset, and they're going to be looking at an ordinal shift in MRS at 6 months. 500 patients they're looking at, hematoma volume 20 to 80, pretty standard. And it started in 2018, and estimated completion is 2024. When I gave this talk about a year and a half ago, it was 2022. And notice that how these trials are being pushed forward by a year or two. And this is exactly the same with the other trial too. I'll talk about it in a little bit, but it is difficult to enroll patients in these trials, and that probably will change. So the second device is called a NICO, brain path system. It does have this obturator, these colorful things here. They are the obturators that are used to advance this colorless sheet into the depth of the hematoma. And using this handpiece here, which has a side port that cuts into the clot in a similar fashion, in a similar mechanism as the Artemis system. It has a side port that cuts into the clot and devours the okay, let me just see 1 second here. Sorry about that. The next system, so that's the trial that is actually built around the NICO system is called Enrich. It has similar criteria, except that it's enrolling within 24 hours of symptom onset. And they're looking at 10% difference in outcomes between patients who had MIS and those who did not, who were treated with conservative management. It started in 2016. And again, it's pushed back by almost 2 years, similar to the MIND clinical trial. When I gave this talk again previously, it was 2019 or so. So there's a lot of issues with enrolling patients in these trials. This trial is planning to enroll about 300 patients, and it is ongoing in the US, about 33 sites. So these two are the randomized clinical trials that are ongoing now. MIND is, I think, ongoing in about 13 sites, and Enrich is in about 33 sites in the US. Hopefully, you will get some good quality data in the coming years. So just to show you our experience here at our center, I want to show you from our initial experiences some examples because we do have long-term follow-ups on them. And of course, since these are our first cases also, it will be important to discuss sort of the flow of patients through our hospital. Sorry, I'm getting some messages, trying to answer this. So our first case, our very first case that we did in this hospital was a 66-year-old female who had hypertension and diabetes mellitus, presented with acute onset left-sided heavy paralysis and loss of consciousness. Husband called 911, unfortunately gave her aspirin. He thought she had a heart attack. He came up with a large volume hematoma, 112 cc's, with a 6 millimeter midline shift. Now, the top panel shows you the bleed before MI treatment, and the bottom panel shows you the bleed after treatment. And this was our very first case, as I said earlier, and we felt pretty good about this. We felt like we probably removed about more than 80% of the hematoma. And just to show you kind of how this works, let's see here. Okay, you can just, okay. You can play this video. Okay. And I can't run this video because I don't have access to the play button down because of this bar at the bottom. Yes. Okay. Right there. Can you pause right there for a second? Okay, perfect. So basically, this is the room setup. We are standing on this left lower side of the screen, and we're looking at two screens here. This is a navigation screen, and this is the endoscopic screen. You notice here that this is the sheath that we're looking through, and this is the wand, the Artemis suction wand that has a band here going through the sheath into the clot. And the dark stuff that you, of course, see down there is the hematoma, and it gets suctioned into this device. And on the left-hand side, of course, we have the neural navigation system directing us in a 3D format in a coronal, sagittal, and axial images that our trajectory is specifically looking at where the clot is. Okay, we can go to the next slide. Okay, here. So here again, let's go back. Okay, so here again is in a static image, just to show you how we look at the clot from 3D angle through this neural navigation system. I think we're using Stealth in this case. Dr. Betancourt, our neurosurgeon, is sitting here and helping me out here, getting into the clot, and then, of course, doing the evacuation. A little bit of a bigger burr hole than we normally do for EVDs. As you can see here, this sheath was in the depth of the hematoma, and progressively it got pulled out. And finally, once it was all completed, the work was completed, it's just completely pulled out here. So how did she do? She did actually great. She was extubated 2 days after admission, which is a day after MIS. She was sitting in the ICU on day 5. And she was cleared for some diet by day 8. So definitely no tracheostomy and peg tube placement, which is a good thing, always a good thing. And then there she is giving us, the thumbs up. You can see, of course, that she has a left facial droop, left arm and left leg were completely weak, but she was in good spirit. I make follow-ups with her every 6 months, and 6 months and 1 year follow-up really is good. MRS3, she's able to walk with a cane. She does have some left arm weakness, difficulty opening her fingers, but once you give her something, she holds onto it and she can carry her cane around, and her left leg has no problems at all. To be honest, she says that she walks at home without any support, so she can even be a little bit close to MRS3, MRS2, but just we want to label her at MRS3. So good outcome. We're very happy with this. So the second case was a guy, a 50-year-old guy, non-compliant with medications, hypertensive, who had cocaine on board. Came in, similar symptoms, left side weakness and loss of consciousness. Again, large bleed, 68 cc with about 8 millimeter midline shift. Again, top panel shows you before evacuation and bottom panel after evacuation. We did have some residual in this case, but not a lot. We actually had a nice reduction in the midline shift. As you can see, right lateral ventricle was not visible here. Here it started opening up already. And he had a 12-day follow-up CT, which showed a nice evolution of the hematoma, some residual left, but it was looking pretty good. And his hospital course was a little complicated. He stayed in the ICU for about 14 days, but when he was extubated after 14 days after admission, he did have some MSS pneumonia, which kept him longer in there, but he got extubated, and he was actually advanced with diet on day 16, and he was discharged with left side weakness, again with no tracheostomy or peg tube placement. Called him actually a few days ago to do a 1-year follow-up with him. Unfortunately, he's an unfunded guy. He's not insured. He was discharged to some charity facility, and according to him, he only got 6 sessions of physical therapy in a span of like 6 months. He says he can walk if he gets some help, if he can get some help from someone. Unfortunately, he lives with a very old mom and a busy sister. He's a big guy. So he's in a wheelchair. That's why I gave him MRS 3/4, but he has no weakness or near normal strength in his left lower extremity, but his left upper extremity is weak. He's unable to say, he's unable to move. But he's in good spirit. So when I wrap up this part of my talk, I really wanted to go through some questions. I know there's so many of you out there who want to ask questions. I get asked some of these questions every time I give this talk. And because we couldn't get to all of you, I thought that I could just put out some, a few things that might answer some of the questions that you may have already. One of those questions is that how do we get to do this? We are interventional neurologists, obviously, and what is the process? of getting to do this. So me and my partner, Dr. Amir Hassan, most of you, all of you know, we have a long-standing interest in intracerebral hemorrhage. We are lucky to train under Dr. Qureshi, who is undoubtedly a giant in intracerebral hemorrhage, who is a PI of ATAC2, as you know. So we train under him. We have that proximity to ICH. We take care of these patients in the ICU. We had exposure to intravenous TPA administrations and treatments of patients. So coming in out of fellowship, we had a very really significant desire to treat these patients, and we take care of them in the ICU, as you know, on a daily basis. It's called an orphan disease, right? ICH, beta ganglia bleed. Nobody really wants to take care of. And neurosurgery says, there's nothing I can do for it. Neurology says, what do we do for it? So usually we're in the neurocrit guys, get stuck with them, and even the primary physicians group say, okay, what do we do with this patient? So it's an orphan disease. Nobody really wants them, so to speak. So when MIS came into picture, we were interested, and we talked to our neurosurgeons, and they're very nice, very kind group of physicians. And they said, okay, if we can bring, this system to our hospital, will help you get trained and proctored and so on and so forth. And at the same time, from back in fellowship, we do place EVDs routinely. We manage them in the ICU. So we went and got trained on a cadaver and came back. And because of our track record with our EVDs and the proctor case that we're doing and the cadaver course that we took, we were allowed to have hospital privileges. So that's one of the questions that I always get. And I hope that that answers that. And the other important question, also I get a lot, is that are you suggesting neurointerventionalists can or should do MIS? And obviously, a very tough question, very political. But I'll try to be as honest as I can in how I view it and how I have consistently answered this question. Now, the most important thing, really, this question also was raised, by the way, just a few days ago, when Dr. Brian Jankowitz and Tudor Jovin gave an ICH talk just a few days ago. So the most important thing is to first, for all of us to get together and help prove that MIS benefits our patients. Really, we have to do that. The same thing we did for ischemic stroke, we have to do it for ICH. We owe it to the patients who actually do horribly. That's the most important thing. And instead of talking about, really manpower, workmanship, this and that. But it is also an important question. So this is how I see it. I think there are three, in my mind, important factors. The first one is timing of MIS. There is a question about when should MIS be done? How close to the ictus should it be done? As you remember, there was a shift towards doing it early. Stage 1 was within 72 hours. Stage 2 was then within 48 hours because there is a feeling that it needs to be done early. I predict, or we see actual evidence that MIS is moving close to the ictus or patient presentation. This is important because there is this almost a third of the patients who present with early hematoma expansion. And hematoma expansion, as most of you know, that it is a major determinant for mortality and for outcome. So any treatment that can be designed for MIS treatment should be including this group of patients. And so should be benefiting this group of patients because a third of the patients could get worse within the first few hours, and we may not be able to get to them, or they will be devastated even if we do something about them. So this is an important factor to consider. The research, high quality randomized clinical trial, will show us exactly when should this be done, which time window, exactly the same way we did with ischemic strokes, probably in the opposite direction that we're going now. The second important factor, I think, is access to MIS. As you know, our neurosurgeons, our precious neurosurgeons, are in a very short supply, even in major cities, let alone in some underserved areas. So I feel it's important that this should be considered, because in the same way we are now seeing with ischemic stroke, transfer delays are excruciating. And we know that every ml increase in hematoma cuts into good outcome by 7%. So this has to be considered in the future. And of course, neurosurgeons' interest, focus, and to be honest, interest in treating stroke is not an easy endeavor to take. It is a lot of firefighting, a lot of burnout, a lot of work for a field that has so much amazing subspecialties, spine, functional, and all these things. Our very short supplied neurosurgeons, may not have enough time to cover all the areas. Especially again, treatment in the early window becomes an important thing to do. And the last thing I want to mention is that volume. Obviously, 15% in the Western Hemisphere, but up to 40% in the most populous part of the world, in the East, and also in Africa, where hypertension prevalence is going through the roof, and hemorrhagic stroke proportions are significantly increasing compared to ischemic stroke proportions. So if all of this and more, I'm sure most of you have more ideas about this. These are just some of the three things that I thought would be important. And if all of this and all the evidence that we'll see in the future proves that MIS works, and it works early, it should be treated as an ischemic stroke, then maybe we can have the discussion that could a group of interventionalists who are interested or trained properly could do this, because I don't see any other profession that is very close to the field, who can closely work with neurosurgery, a bunch of guys who are highly skilled with a lot of finesse with what we do, and really honestly expertise in the field. So I don't see any better profession that can be trained to either back up or help our very few neurosurgeons who might be interested in doing this form of stroke. And of course, the MIS is doing MIS ICH in the angio suite. As most of you know, DSA should be done to rule out a bleed, a vascular malformation, small ADMs, and so on and so forth in the cath lab. And then you can just flip the patient and do the MIS right there and then. Our flat panel CTs are getting really good, as most of you know. They're almost becoming as good as the CT scans downstairs. We have so many cool techniques, the overlay techniques. We can overlay vascular imaging, soft tissue imaging, 3D, 4D. All these things will be helpful in navigating and getting to the clot. And of course, decreasing the delays in transfer from one place to another. So again, most of this really is dependent upon what we can do as a team, as a whole neuroscience team in the future. We need to help prove it. What we have done for ischemic stroke or LVOs, we need to do it for hemorrhagic stroke. I talked about enrollment, delays in enrollment earlier. In both randomized clinical trials that are ongoing right now, there is significant delay, 6-7 years of what we're looking into. And compare that to the ischemic stroke trial pace that we've observed. So it really is important that we get together, help one another as a team. And that's exactly what's happening with the trials that are ongoing. It's just moving a whole country as far as getting enrolled one patient into either ENREACH or MIND clinical trials. So we need to get together, expand the horizon, and then be part of this. So if that happens, then we'll have a lot more to talk about. I'll quickly go to my second talk. I promise I finish quickly. I'm sorry about the delays and the technical difficulties that we've had, but I want to thank Dr. Betancourt sincerely. He is the neurosurgeon who's been helping us with this program from the beginning. Very skilled neurosurgeon, of course, extremely kind and a gentleman. So the next topic that I want to cover quickly is DOAC reversals on MIS. I'm sorry if I'm getting into the questions and answers time window, but I have tried to include questions and answers in my talk, and I hope that answers some of the questions that you may have. A lot of people are taking DOACs or factor Xa inhibitors for multiple indications, mostly for AFib and or thromboembolic complications, thromboembolic diseases, such as DVTs. And almost close to 200,000 patients get hospitalized because of complications. Almost 14% of those will die from those complications because they are supposed to be severe bleeds. Data that looked into 45 hospitals with over 3,000 patients show that most of these patients are on either rivaroxaban or apixaban here on the left side, and almost 17% of those bleeds are intracranial hemorrhages. Annual bleed rates, as you remember from the non-valvular atrial fibrillation studies that compared apixaban with warfarin, rivaroxaban with warfarin, we have 0.33% for apixaban and 0.5% for warfarin. For rivaroxaban, but of course, the annual rate overall can be anywhere between 0.25 to 1.1%. A quick overview of the coagulation cascade, a very simplified form from UpToDate. And you can see the direct 10A inhibitors and then direct thrombin inhibitors here listed. And factor 10A inhibitors, which are by far the most commonly prescribed medications, are direct 10A inhibitors. Of course, we know the heparinoids are also inhibitors of both 10A and thrombin. Reversal agents for dabigatran, as you know, Paxbind has been proven to be effective. It's less prescribed these days. We'll be focusing on the factor 10A inhibitors. And for factor 10A inhibitors, it's a toss-up between andexanet alpha or andexa and 4-factor PCC. So there is no randomized clinical trial comparing these two. And as we talk about this very difficult topic, there's really no news that I bring to you. It's just really to review what we have out there very quickly and then see if you have any questions. We are dependent upon case series, preclinical studies, and case reviews in some preclinical models, and I will try to review some of the most important studies out there to help us out. Other treatment considerations before I go into the comparison between andexanet alpha and PCC, antifibrinolytic agents can be used, especially in life-threatening or severe hemorrhages. Dialysis is not helpful in factor 10A inhibitors. It is very helpful in dabigatran. Dabigatran can be completely removed can be removed significantly rather by dialysis, but not factor 10A inhibitors because they are highly protein bound. Activated charcoal can be used, especially if the intake was within those early hours. The same thing with dabigatran. If it was taken within 2 hours, you can give activated charcoal. And of course, if the patients can swallow, most of our patients with intracranial hemorrhage are not, unfortunately. As you know, factor 10, plasma, cryoprecipitate, recombinant factor 7 are not. There's no evidence for those. They might actually be harmful, except for a very small group of patients, like those who come with traumatic ICH with evidence of PIC and so on and so forth. So, focusing on andexanet alpha and 4-factor PCC, it's an emergency reversal for apixaban and rivaroxaban. As you know, it is a decoy protein. It's factor 10A itself. It's just inactive catalytically. So it basically goes into the bloodstream and it binds to all the factor 10A inhibitors and then sequesters them away. It was approved based on a single-arm clinical study through accelerated approval process, as you know, because there was no treatment. There was no approved treatment to reverse these agents. But because it was approved through the AAP process, it's required to come up with a phase 4 clinical trial, which is ongoing, planning to recruit about 400 patients, hopefully to be completed in 2024, 23-24. And we'll see what that is. That's a direct comparison, sort of head-to-head between Andexa and all the other treatments. But looking at the very first study that led to the approval of Andexa, again, it's a single-arm study, 64% ICH. Most of the indications for factor 10A inhibitors was AFib. Primary outcomes were surrogate outcomes, as I discussed earlier. Hemostatic efficacy, anti-factor 10A activity, and of course, there were some safety outcomes, thromboembolic complications, and so on. Interestingly, there was no correlation between reduction in factor 10A activity and achievement of hemostasis. There's so many critics on this study, as you all probably know. They excluded patients who were less than a GCS of less than 7 and ICH more than 60 cc. And anti-factor 10A activity is not a patient-centered outcome. It is a lab result, although it's important. and BP control was not reported in ITH patients. And blood pressure, we know, is an important determinant of hematoma expansion, deterioration, and so on and so forth. So because of that, this single-arm study, which led to the approval of Andexxa, has been critiqued a few times. Some questions that I promised that I heard about, of course, Andexxa as a treatment of, DOAC reversal is that it has a short half-life. Can it rebound? And patients have rebound hemorrhages. The pharmacodynamic half-life is 1 hour, although it clears within a span of 3 to 4 hours from the body. What happens if the DOACs that are sequestered away by the Andexxa, now when they are no more sequestered, when they are released back into the circulation, could they be active? And is there a need for a rebolus with this treatment because of its short half-life? So some of the answers I get is that 2 hours is adequate to form a stable hemostatic plug. While the Andexxa is bolused and infusing over 2 hours, that is adequate to form a hemostatic plug. And there is no safety or efficacy data that shows repeat bolus is indicated. Now, to answer question number 2, and instead of going through this text now, let me show you these graphs. And the top graph basically is showing the Andexxa net alpha bolus for reversal of apixaban and rivaroxaban, but the bottom graph shows the bolus and the infusion at the same time. So let's focus on the bottom graph here. On the y-axis is the anti-factor Xa activity. On the x-axis is time in hours. And you notice here that black curve is for placebo and red is for Andexxa. And when it was first given at hour 0, the activity level is probably 170, 175 nanograms per ml. It goes down significantly to almost close to 0, and then it stays like that as long as the infusion is ongoing for 2 hours. As long as the infusion is completed, then the anti-factor Xa activity starts to rise to meet the placebo concentration, anywhere between 4 to 6 hours. And this is the fear people have. When it's rising up like this, can patients rebleed? But then the answer, of course, is no, because number one, the concentration is not going to be as high as it was. And number 2, they are released slowly into the circulation. Hemostatic plug most likely occurred by then. And then, of course, the body's metabolism will clear those, those anti-factor Xa inhibitors as they join the circulation. So there is no significant risk of rebleeding. And the second explanation, actually, is very important explanation, is that what's called endogenous thrombin potential. This is really the production of thrombin as measured by endogenous thrombin potential. Very interesting to look here that even after the first 2 hours, the endogenous thrombin potential is on the y-axis and hour on the x-axis. Even after 2 hours of infusion is completed with Andexxa here, when the endogenous thrombin potential is high, beyond that, you see the endogenous thrombin potential, or thrombin production, in short, is staying high with Andexxa. While in control groups, it is actually, staying lower. Why would it be continuing to persist despite this was a very short-acting drug? And there is something that we all know about, inhibition of tissue factor pathway inhibitor that Andexxa has as a separate mechanism of action. So moving on quickly to 4-factor PCC, this current standard of care, the mechanism of action is, as you all know, as we're introducing factors into the circulation, it would overwhelm or overcome the inhibitory potentials of DOACs, and it has also marginal effect when the DOAC concentration is lower. Is there data? Yes, there's a bunch of case reports, but they are limited by the small numbers and really adjudication of outcomes, hemostatic efficacy, thromboembolic event adjudication, the timing, when do you count those, mortality. All these things are all over the place. Very difficult to conclude. This is courtesy of one of our PharmD students from UT Health System, by the way. And so there was a meta-analysis that basically showed hemostatic efficacy with 4-factor PCC close to 70%. And these are the mortality and thrombosis risk. And the conclusion is really, we don't know if PCC is better than just holding the anticoagulants. So cost, as you can see here, is a little more expensive. With Andexxa compared to 4-factor PCC. It depends on the dose. You can see these tables and compare for yourself. And dosing depends. Dosing of Andexxa depending on, of course, timing and the amount of the dose that the patients are on. multiple guidelines from different societies are showing mixed result. The AHA says Andexa can be used. The CHEST says use a specific agent. American College of Cardiology says 4-factor PCC, and Neurocritical Care says 4-factor PCC. So really, this shows you the lack of evidence, strong evidence, going one way or another. So for the most important clinical question that all of you may have, which I had, is that in terms of safety and efficacy, which one is better, Andexa or 4-factor PCC? There is no head-to-head comparison, as we said in the beginning. But this was just published a week ago from the Mass General group. I just thought it was interesting because it just came out literally. But it's a single-center retrospective study looking at patients who took Andexa and also 4-factor PCC for DOAC, factor Xa associated with hemorrhage. 18 patients on one arm, 11 patients on the other. Hemostatic efficacy, almost 89% versus 60%. Good functional outcome was better in the Andexa group, but thrombotic complication was higher. And of course, cost was higher. Now, they're saying definitely the outcomes seem to be better in this retrospective review, but patients who had 4-factor PCC had pre-reversal, low GCS, and also larger intrastable hemorrhage volume. There's really nothing much to make out of this, but it's a very good review. And to be also fair, the Portola Pharmaceuticals have done this multiple comparisons. Since there is no head-to-head comparison, they are pulling patients from multiple clinical trials and trying to do propensity scoring, propensity score matching, and then see if there is any benefit with one drug versus the other. Again, these are not published studies. I just wanted to be fair and show everything that I have come across with. They compare two studies, Annexa 4 and Orange 3 studies, a prospective study in UK, and they cleaned the data as much as they can. They did propensity score matching. The red column was before matching, orange column was after matching for their baseline characteristics, and they found that in the ICH subgroup, 15% 30-day mortality for Andexa and 48% for 4-factor PCC, and relative risk for 30-day mortality favored Andexa. Again, the biggest limitation for this study is they were not able to control for some of the most important confounders, such as bleeding size. And they suggested that future comparisons should account for that. It's a no-brainer for sure. Another study, over 3,000 patients from 45 hospitals, again, looked into all patients who came in with DOAC, specifically factor Xa inhibitor-related hemorrhage, and looked at ICH specifically and showed 9% for Andexa, 25% for 4-factor PCC for in-hospital mortality. So again, this is very difficult to interpret. It's not published yet. It's not even peer-reviewed. I saw it on a poster, but baseline bleeding severity has not been compared very well, has not been accounted for. So as a summary, again, courtesy of Ashley, who put together this slide, is that in terms of hemostatic efficacy, patient-centered outcomes, thrombotic risk, mortality, functional outcomes, it is really all over the place. They are comparable in hemostatic efficacy, more thromboembolic complications with Andexa, less mortality. However, most clinical trials that looked at PCC included patients with low GCS and high mortality, high ICH score. So conclusion-wise, I have to stick to what my hospital conclusion is. Basically, there's so many issues unanswered by the clinical trials, and so far we're going to wait. We're going to have to wait for the phase 4 clinical study from Andexa. We'll continue to look into the study and then go from there. But clearly, there is no convincing evidence to suggest one way or the other. Sorry that I rushed towards the end, but thanks for listening. If you have any questions, please, that I can answer.
Okay, great. Dr. Tekle, thank you so much. Really going through a lot of information very, very quickly on a topic that's very new and interesting, and one which we can all learn from. Now, for the sake of time, I think we're going to move forward to the next session. There are a couple great questions that have come up, but maybe what I'll ask is, Dr. Tekle, if you can answer those questions in the text by replying, by typing, then we can stay on time with the rest of our talks.